Good evening, everyone, and welcome. We're going to go ahead and get started. My name is Jason Fisher. I'm a member of the Communications Committee at SIR and a current surgical intern at the Mount Sinai Hospital in New York. I want to welcome you all to another RFS webinar entitled Venous Thromboembolic Emergencies in the Oncologic Patient. And before we dive into it, let me get through my usual disclaimers. Tonight's session will be recorded as usual and made available on the SIR-RFS IR Education YouTube channel, so do check back and revisit it and any others anytime you'd like. Second, to respect both our presenters and our audience's time, ask questions as we go along, but please do so using the questions chat box on the GoToWebinar control panel. I'll be moderating the chats throughout the evening, and this way I can present your questions at the end or as Dr. Bryce prefers when we go through her slides. So moving into our presentation for the evening, I'm thrilled to be able to introduce our speaker tonight, Dr. Yolanda Bryce. Dr. Bryce is an alumnus of the Loma Linda University School of Medicine, after which she completed her diagnostic radiology training at the Mount Auburn Hospital. Following her time in Boston, Dr. Bryce then completed fellowships in both VIR at Miami Cardiac and Baptist, as well as breast imaging at Memorial Sloan Kettering, where she now sits on the faculty. So, Dr. Bryce, with all that being said, the floor is yours.
Thank you so much for the invitation. So I'm going to talk to you about venous thromboembolic emergencies in our cancer patients. Here at a cancer center, we see so many patients with VTE, and a lot of times they ask the interventionalist to be involved with their management. So there are some key things to know as an interventional radiologist, and especially in our oncologic population, as this is the type of patient that is very prone to venous thromboembolic diseases. And sometimes it's an emergency. So a lot of times these patients, they don't just present with a simple DVT and something needs to be done emergently. So to begin with, VTE emergencies are basically two entities. It is Phlegmasia, cerulea, dolens, and it is massive PE. I include some massive PE because it is a topic that is more and more discussed, and I believe it is a good time to discuss it now, as the interventional radiologist is becoming more involved in this entity. We'll begin with Phlegmasia, cerulea, dolens. This entity is due to diffuse venous thrombosis that compromises arterial flow. In other words, there is so much venous thrombus that it therefore compromises the flow of the arterial blood and therefore manifests with the leg being very painful, very swollen. It could be purple, and most importantly, there is loss of distal pulses. The entity is in fact very rare. Risk factors include malignancy, heparin-induced thrombocytopenia or HIT, other coagulation disorders. When there's a presence of an inferior vena cava filter, that also may place the patient more likely to develop this rare entity, as well as contraceptives, pregnancy, surgery, and trauma. Now, malignancy is the most common risk factor for Phlegmasia, cerulea, dolens, with a rate as high as 33%. And when this sets in, the progression to venous gangrene happens to 40 to 60% of cases. It is a very morbid disorder. It is rare, but very morbid. It is associated with high mortality rates of 20 to 41%, and amputation rates are as high as 12 to 50% in patients who survive the diagnosis. There has been an attempt to try to classify Phlegmasia, cerulea, dolens, but in honesty, it is such a rare entity that just the importance is just to be able to recognize the phenomena and try to treat it effectively. So the classification, some have advocated that you could call it non-complicated, and this would be the patient that just has the distal pulses missing, but no real changes to the leg. They still have their sensation, their motor function, and so forth. And so this could be called non-complicated. Impending venous gangrene is when the leg is already compromised. They may have a decrease in sensation. They may have just a lot of pain and visual changes, decreased motor function. And these are the patients that you would call impending venous gangrene. And then the patients with venous gangrene are the patients that cannot be salvaged with revascularization. It is just the patient that requires an amputation. So the diagnosis is based solely on just clinical exam where you feel that there is no distal pulse and when ultrasound demonstrates a lot of venous thrombus. When we have diagnosed this entity, the goal of treatment is to improve venous flow. So we will use many different things to try to reconstitute this flow. We use anticoagulation as just baseline. The patient comes in, has a large DVT. You would probably start the patient on a heparin drip or so forth. But something more aggressive is needed because this patient is at very high risk of not only losing their leg, but of dying. So there has been some departments that have chosen to use systemic thrombolysis because, again, this patient's life is at risk, so they might use systemic thrombolysis, and even if they're exposing the patient to systemic TPA, it could be worth it in this situation. Other places have now started using catheter-directed thrombolysis because, again, the idea is that you're putting thrombolysis at the site of the venous thrombus and you're not exposing the patient to systemic thrombolysis. To get improve the venous outflow more quickly, if you need to act very quickly, you could invoke thrombectomy, which either can be done surgically or under catheter-directed methods. And again, sometimes these patients, you need to take them immediately to surgery. You need to perform a fasciotomy. If there is a lot of if the gangrenous is moving quickly, and if there's compartment syndrome, and then of course, what we're trying to avoid, amputation. This is an example of a patient I had. It's a 57-year-old female that had uterine cancer, and she was status post-hysterectomy, and she presented with left lower extremity swelling, and of course, the very dreaded absent pulses. So this patient, when we look back on their imaging, you can see that the patient has this left common iliac vein that is being markedly compressed by the right common iliac artery. And because of this compression, we call this May Thurner's, the patient was already prone to have a problem with venous outflow. But when we put on top of this patient that has uterine cancer, this patient becomes hyper-coagulable, and therefore the patient is more prone to get a DVT. And in fact, this patient did develop a DVT that was so severe. So we brought this patient in the angio suite, and we tried to actually some thrombolysis overnight to try to improve the outflow. And if you see here, the next morning after we had started catheter-directed thrombolysis and some thrombectomy, there is very little fluid reconstituted. So we decided to perform mechanical thrombectomy. This is just a very small video that shows how the angiojet device works, the rheolytic thrombectomy device, that what it uses is pulse spray and aspiration of the thrombus. So we use this in this patient. This is what it looks like on fluoroscopy. This is where the jet and aspiration occur. And we required to do additional work with angioplasty and stenting. And at the conclusion of the procedure, we had reconstituted flow in this patient, and the patient's leg was salvaged. Now, when we're trying to do mechanical thrombectomy, especially in the lower extremities, we have a multitude of different devices that we could use. We can use an aspiration thrombectomy. We could use something more simple called the cleaner, which is just this rotational thrombectomy device that you can see in this picture. So there are many options that we could utilize. So that concludes my section on Phlegmasia, cerulea, and dolens, and so I'm going to move on to massive and submassive PE, which is becoming more and more of a very interesting topic that interventional radiologists are talking about. A little background: incidence of PE. So 60 to 70 per 100,000 people present with PE in the general population, and a very high number, 20%, is due to active cancer. PE is especially high in patients that have malignant brain tumors, adenocarcinoma of the ovary, pancreas, colon, stomach, lung, and prostate. When we look at PE, acute PE, we can divide them into three categories. There is massive PE, which is a small amount of patients, and these are considered our high-risk patients. They're about 5% of patients. And these patients present with sustained hypotension, or they require pressors, vasopressors, or they could have such severe bradycardia that they have symptoms related to the bradycardia, meaning they have signs or symptoms of shock. So these patients are the patients with PE with hemodynamic compromise. The second category is that of submassive PE. And these are the patients that have a lot of PE, but they're systemically normotensive. Their blood pressure is normal, they may be tachycardic and so forth, but they are normotensive. But we see evidence of right ventricular dysfunction and ischemia by looking at the troponins. The echocardiogram will show that the heart isn't moving so well. The CAT scan will show that the right ventricular, left ventricular ratio is too elevated. And then there are some markers of right ventricular failure, the BNP and the pro-BNP, and EKG changes that will show that something is wrong with the right ventricle in the setting of PE. And then we have our patients that have the simple PE. These are the majority of patients, about 55%, that number one, they're systemically normotensive, and secondly, they have no evidence of right ventricular dysfunction or myocardial necrosis. So when we look at this mortality rate and try to equate them with the kind of PE they have, we see that it's very important. So when we have a patient with massive PE, we will see that the mortality rate ranges from 18 to 65%. If the patient has some massive pulmonary embolism, now the mortality rate is less. It is 5 to 25%. And this is important when we start talking about treatment. When the patient has only simple PE or uncomplicated PEs, this patient is normotensive, no evidence of right ventricular compromise, the mortality rate is about 1%. So again, massive PE, it is the patient that arrives hypotensive. And so yes, the CAT scan will show, the CT scan will show that there is a large pulmonary embolus. This is showing a large saddle pulmonary embolus on the CT of one of my patients. But more importantly, the patient is hypotensive. What is the pathophysiology behind it? It's important that we know, because this pathophysiology, in fact, is the basis of why the interventional radiologist does what he or she does. So the right ventricular the right ventricular compromise is why we do our intervention. So how this happens is that first the pulmonary artery is obstructed, right? And the pulmonary artery represents the afterload to the right ventricle. The right ventricle is only meant to beat against a very low resistance system. So once the afterload is increased in the pulmonary artery, this increases the right ventricular afterload and increases the right ventricular work. And the right ventricle is not built for that. So this very thin-walled right ventricle, thin, weak-walled right ventricle dilates, and it cannot generate enough force to overcome the afterload of the elevated pulmonary artery pressure. And when it dilates, it starts pushing against the left ventricle. And when it pushes against the left ventricle does not have enough room to fill, and therefore the left ventricle output is compromised. And so the left ventricular output decreases, and therefore the coronary artery perfusion is decreased. And then the coronary arteries that are supposed to be supplying the right ventricle are compromised, and so that results in right ventricular ischemia. And then right ventricular ischemia results in more right ventricle dilation and poor function. So it's a cycle that is it's a cycle that worsens and worsens with time. So because of this cycle that is kind of a downward spiral, we kind of have to stop it in its tracks. So what do we use to treat massive PE? We have these four options. We have anticoagulation, we have systemic thrombolysis, we have surgical embolectomy, or catheter-directed options. So first, and conceivably so, with a patient with massive PE, especially historically, surgical embolectomy was the number one thing that patients would undergo because of massive PE. With surgical embolectomy, however, the mortality rate is about 27%. It is not available everywhere, and it's a procedure that may be difficult to learn because the training gap, according to one study, is about 15 years. So when they were trying to decide, well, how should we treat these massive PE patients, especially in places that don't have surgical embolectomy available, they said, well, what happens if we treat the patient with systemic thrombolysis versus anticoagulation alone? Of course, we all love randomized controlled studies as we are in this era of evidence-based medicine. So this person, Sanchez, decided he wanted to make a very good randomized controlled trial to answer this question of anticoagulation versus systemic thrombolysis. Now, this study, when it opened, it had to stop after enrolling only 8 patients. Why? Because the 4 patients that were placed in the thrombolysis arm survived, and the 4 patients that were placed in the anticoagulation arm all died. Therefore, this study was stopped, and we kind of see that, maybe anticoagulation is not enough in these massive PE, and systemic thrombolysis could be the answer. And so we have a solution of what to do even if we don't have surgical embolectomy available. So when we use intravenous thrombolysis, right, we are, of course, afraid of bleeding. In the randomized trials, 13% of patients that had intravenous thrombolysis, 13% had major bleeding, and 1.8% had intracranial hemorrhage, which of course is the very scary outcome of what can happen with intravenous thrombolysis. In clinical practice, so those are the randomized trials in these centers that are very equipped for these procedures. What about in the community? Well, in the clinical practice, the major bleeding major bleeding can result in 20% of cases that receive intravenous thrombolysis, and 3% have a risk of intracranial hemorrhage. So this is the reason why systemic thrombolysis is withheld in up to 2/3 of patients, because of the very scary outcome that could be this major bleeding. So in 2/3 of patients with massive PE, this is withheld. So if we're so scared about intravenous thrombolysis, what about other options? What about catheter-directed therapies? I will come to that after I discuss the massive PE. So again, patients with submassive PE have no hypotension. They have, however, signs of right ventricular dysfunction. They have an RV-LV ratio greater than 0.9. They have right ventricular dysfunction on echocardiogram. They have elevated troponins, elevated proBNP, and EKG changes. And again, the mortality rate of submassive PE is not as high as the mortality rate of massive PE. The mortality rate of submassive PE is about 5 to 25%. So when we're looking at the mortality versus the mortality of the other things, of massive and the mortality rate of uncomplicated PE, we're kind of in the middle with submassive PE at 5 to 25%. So it's not as low as 1%, and obviously it's not as high as 18 to 65%. So what are our options to treat this entity? If we do anticoagulation, isn't enough, because these patients do have right ventricular compromise. And well, should we do surgical embolectomy? Well, the mortality rate of surgical embolectomy is about 27%, and the mortality rate of submassive PE is only about up to 25%, so that doesn't really make sense. How about systemic thrombolysis? Does it provide too much morbidity for submassive PE? And how about other options, catheter-directed therapy? And we'll go over a few trials. These are landmark trials that I believe every interventionalist should know: the PITHO trial, the Seattle 2, and the Ultima trial. In order to answer the question of systemic thrombolysis, we look at, specifically in the population of submassive PE, we look at the PITHO trial. This trial was a multi-center, double-blinded, placebo-controlled, randomized trial. It had over 1,000 patients. All of these patients had submassive PE. And the patients were randomized to undergo fibrinolysis or thrombolysis, and they received 30 to 50 milligrams IV of tenecteplase. Now, I should say, though, that the dosage of a massive PE is usually 100 milligrams IV TPA. So this was a smaller dose that they used for systemic thrombolysis in these patients with submassive PE, not massive PE. And both groups, both the patients that had the thrombolysis had heparin as systemic anticoagulation. So when they looked at these patients, they were not able to establish a mortality benefit. They were not able to establish a mortality benefit, but what they did demonstrate is that there was a significant difference in hemodynamic decompensation between patients who had thrombolysis versus patients that had placebo. So this was important. Perhaps if we had had even more patients, it's hard to have more than 1,000 patients, but if we had more patients, maybe we could have demonstrated a mortality benefit. But at least these patients did not have hemodynamic decompensation, therefore it's not a patient that required resuscitation, and so forth. Also very important, this study demonstrated safety outcomes, or at least answer the question about safety in this group population that has some massive PE and we're giving IV TPA or IV thrombolysis. So the major extracranial bleeding and the intracranial hemorrhage were all significantly increased in patients that had IV thrombolysis versus the patients that had just systemic anticoagulation. So because there were patients, you can look at this number, right? It's a patient with IV thrombolysis had 10 hemorrhagic strokes versus 1 under placebo. So this is, of course, worrisome, and this is what people are worried about, and this is why people don't like to use systemic thrombolysis. So the conclusion of the PITHO trial was that, number one, it did improve hemodynamic decompensation. So it did provide a morbidity benefit, but they did not demonstrate a mortality benefit. And then very importantly is, again, it showed that there is statistically increased intracranial and extracranial hemorrhage with IV thrombolysis versus patients that do not undergo IV thrombolysis. So because of this question of, well, is there something else we can do? There is 2 studies that should be known. There's more studies now, but the 2 studies that we should know as IRs is the Ultima and the Seattle 2 trial. So the Ultima was an attempt to do somewhat of a randomized controlled trial or randomized trial where they had 59 patients. They were randomized to catheter-directed thrombolysis versus heparin alone. And what they saw was when they had the patients go on catheter-directed thrombolysis, there was, in fact, a difference in the initial right ventricle, left ventricle, and the right ventricle, left ventricle ratio 24 hours after treatment. So we'll talk a little bit also about the importance of the right ventricle, left ventricular ratio. But when we did put patients on catheter-directed thrombolysis, there was a statistical improvement in the RV-LV ratio. So also, it showed that the other markers that somebody might look at, the pulmonary artery systolic pressure, the right atrial mean pressure, the cardiac index, they're all improved when the patient, or I should say they're all improved within 24 hours when the patient undergoes catheter-directed thrombolysis. More importantly, yes, that was nice to note that the right ventricular, left ventricular ratio, the RV-LV ratio, and other factors are improved with catheter-directed thrombolysis. Even though that was nice to know, the more important and interesting thing are these safety outcomes. So if you remember the PITHO trial that showed all this major extracranial and intracranial hemorrhage, in this trial, there were zero deaths in the catheter-directed therapy group. But more important, there were no major bleeding complications in either group. No major, and there was no intracranial hemorrhage, 0. So this was important to note. The Seattle 2 trial really kind of gave the interventional radiologists the technique that can be utilized and standardized among practices to know how we can treat these patients with these large PE that are compromised. This trial looked at both massive and submassive PE. And it was a prospective single-arm trial, so it was not randomized. It's just a single-arm trial, and they looked at catheter-directed thrombolysis. When they looked at this, they saw that after the procedure, compared to 48 hours after the procedure, there was improvement in the mean RV-LV ratio. There was improvement in the pulmonary artery pressure, in the mean modified Miller index. So all of these things were improved when we had catheter-directed thrombolysis, and we compared patients before the procedure and 48 hours afterwards. So what is the importance of the RV-LV ratio? I keep mentioning it. The Ultima and the Seattle 2 trials heavily relied on the RV-LV ratio before and after the procedure. Well, to answer this question, there is a study, it's retrospective, with 120 patients that they looked at acute PE, and they looked at the outcomes after 3 months between patients with RV-LV ratio greater than 1 and RV-LV ratio less than 1. And they saw that there was a positive predictive value for PE-related mortality with an RV-LV ratio greater than 1, which was 10.1%. And there was a negative predictive value for an uneventful outcome with an RV-LV ratio of 1 or less, which was 100%. So they use a cutoff of 1. We all know that greater than 0.9 is abnormal. They use a cutoff of 1, and it just makes things very simple. There was another retrospective trial. This was much larger. And they used, again, the RV-LV ratio cutoff of 1. And they saw, there's an error in this slide, but they saw that the RV-LV ratio of 1 was independently associated with short-term mortality. I just have a couple of cases to show. This first slide is of a patient with massive PE. It was a 39-year-old female patient. She came in because of a myomectomy, syncopal episode, shortness of breath, and tachycardia on postoperative day 1. When we saw her, she was hypotensive. She was hypotensive initially, but when we saw her, she had a blood pressure that was kind of borderline. She was tachycardic, and she had a pulmonary artery pressure of 63. On the CAT scan, on the CTA of the chest, we saw that, number 1, there is a saddle embolus, and more importantly, again, the right ventricle ratio and left ventricular ratio is increased, because you see how dilated the right ventricle is. So we initiated in this patient catheter-directed thrombolysis. And you could see that before the initiation of thrombolysis, you can see that here there is a lot of filling defects. The right lung isn't filling well. And at the conclusion, after 12 hours of catheter-directed thrombolysis, you see that most of the left lung is perfused. So a big difference between before and after the procedure. So in this patient, the symptoms normalized in 24 hours. The blood pressure was normal, and she was sitting well on room air. So in addition to catheter-directed thrombolysis, we can do mechanical thrombectomy. And this is described as an attempt to demonstrate the different procedures that can be done and the different outcomes that can be done with mechanical thrombectomy. And the perfect trial is what we will use. So mechanical thrombectomy, I like to use it when I have a desire for rapid response in massive PE patient. This patient is crashing. This patient is hypotensive on pressors. I want a result right now. It might not be a pretty result, but I just want to stabilize the patient. So that's a reason to use mechanical thrombectomy. It can also be used to avoid costs and issues associated with overnight thrombolysis. A lot of these patients require an ICU bed. And so if you're able to accomplish the same job with mechanical thrombectomy, then hey, you spare the patient this overnight stay with thrombolysis. And you can use it when there is contraindication or failure of thrombolysis, or if they're at high risk. So the perfect trial was a trial where they looked at 101 patients. 28 patients had massive, and patients had some massive PE. And they looked at catheter-directed mechanical or pharmacomechanical thrombectomy, and they saw that the success rate, the clinical success rate, is very high, above 85%, and in massive cases, and some massive cases is 97%, which is great. It works. They show that the mean pulmonary artery pressure decreased substantially, and of course, very importantly, and what we care about is that the right ventricular strain on echocardiogram improved. And again, no major procedure-related complications, no major hemorrhages, and no hemorrhagic stroke. This is a case of a patient I had with chest pain and massive PE. The patient is 44 years old, had left lower extremity DVT. And here on physical exam, you'll notice that the blood pressure is 78/45. So right there, you know, patient with PE with this blood pressure, that's a massive PE. The patient had troponin elevation, diffuse ST depression, and here on the echocardiogram, the right ventricle is a lot larger than the left ventricle, and the wall motion was impaired. The patient had a VQ scan. I don't know why they did that, but we asked for a CT so that we could really characterize where the pulmonary embolus was. And of course, the patient has this large saddle embolus, and the patient has this right ventricle that is larger than the left ventricle. So when we took the patient to the angio suite, the pulmonary artery pressure was 48/12. Now, I want to say something about the pulmonary artery pressure. A lot of these patients, when they are acute pulmonary artery pressure, they do not have a pulmonary artery pressure that is through the roof in the 60s and higher, because this is an acute process, and the pulmonary artery bed takes a while to actually build this kind of resistance to resemble pulmonary artery pressures of very high. So 48/12 in acute setting is actually very high. So this patient, we took them in. It was a patient that was hypotensive. We wanted results right now, so we used aspiration thrombectomy with an indigo aspiration device, and we kind of used a strong vacuum to try to pull out the pulmonary artery thrombus. And so here you can see that there is a paucity of perfusion in the left lung, and when we performed aspiration thrombectomy, we restored it here. It's not pretty. You still see a lot of the thrombus there, but it's a lot better. So this is just a small video just to demonstrate how aspiration thrombectomy with indigo penumbra works. It's just one of the many things that we as interventional radiologists can use to perform mechanical thrombectomy. This can be used in the pulmonary arteries as well as the lower extremities. All right, so this is a patient that underwent this procedure, and you will see that the saddle pulmonary embolus is not completely resolved, but it's a lot better. And more importantly, the right ventricle, left ventricle ratio is normalized. So we can perform mechanical thrombectomy without thrombolysis. You do not have to back it up with thrombolysis. If you don't have to, this was a patient that presented. This patient had lung cancer and had this very large chest wall hematoma. And the patient it's interesting to me always, because sometimes the burden of PE doesn't really reflect how much symptoms the patient has. This patient has here at the endpoint where we see the pulmonary arteries at the right and left. And again, when we tried to look at the RV-LV ratio, we see that it is increased. So this patient has a large chest wall hematoma, so it's not an anticoagulation candidate, and they're worried about bleeding, so you can't do thrombolysis. So this patient underwent mechanical thrombectomy only, and you will see that the patient had this large thrombus sitting in the right pulmonary artery. You see positive perfusion to the right lung, and after after mechanical thrombectomy, we use aspiration thrombectomy. You see that there is better perfusion to the right lung, especially the lower portion, but it's not pretty, right? You still see a lot of filling defects, and this is kind of what we see when we perform mechanical thrombectomy. It may not be 100% pretty, but what's important is that you help the patient hemodynamically, you improve the right ventricular function. So every institution probably has some kind of way that they try to help these patients. In my institution, we developed just something to try to guide us to see. We use the Simplified Pulmonary Embolus Severity Index, and we try to say, okay, is this patient kind of low risk? And if the Simplified Pulmonary Embolus Severity Index is greater than 2, and we use 2 because in this index, you automatically get 1 point for cancer, and all of our patients have cancer, so we use a score of 2, but your institution might use 1. And then when we have an index greater than 1, we say, okay, can we help these patients with more aggressive therapy than just anticoagulation? Does this patient have massive PE? Should we then, if the patient has massive PE, can we do surgical embolectomy, or should we consider catheter-directed therapy? And if the patient has, so massive PE is actually kind of easy because you know something must be done right now. And if the patient, though, has some massive PE, then we at my institution, we look at, we want at least to see 2 things abnormal to represent right ventricular dysfunction to say, should we treat this patient or not? So we look at either the RV-LV ratio, the systolic function on echocardiogram, is the BNP elevated, the troponin elevated, are there EKG changes, etc. So we want to see at least 2 of these things. And if we see 2, then we consider catheter-directed thrombolysis. If the patient is not a thrombolysis candidate, we consider mechanical catheter-directed thrombolysis. So this concludes my talk on venous thromboembolic emergencies in the oncologic patients. Again, it's a patient population that are very prone to these VTE disorders. And the interventional radiologist has this armamentarium to be able to treat these patients. And so we should utilize them to benefit these patient populations. Thank you.
Thank you very much, Dr. Bryce. That was excellent. If our audience has any additional questions, go ahead and get them in now. We'll wait a few minutes in case any roll in. Otherwise, that will conclude tonight's presentation. Okay, I don't see anything else coming in, so I just want to extend another thank you to you, Dr. Bryce, for taking your time out tonight to do this, as well as the Interventional Oncology Service Line for proceeding to get this together and really doing the legwork in terms of getting experts in who are really invaluable to the RFS and making the mission of outreach to students, residents, and fellows as well possible. So thank you again.
Thank you. Thank you so much.